Thank you for hitting play, and welcome to the series we're calling Data Pioneers. We're bringing together the brightest minds in the healthcare industry, supporting the transition to value-based care. We'll be highlighting the best practices, tools, lessons, and advice with a focus on data and analytics. I'm your host, Rich Waller from WellStack, and we're very excited to have you join us today. Dr. Patel, welcome to Data Pioneers.
Hey, Rich, great to be here, buddy.
Yeah, great to see you as always. Maybe by way of background, you've had such an amazing, kind of career here, right? I mean, you've been an advisor, a consultant, an executive, educator, right, professor. So I'd love to hear a little bit about, kind of your journey and how you ended up in healthcare IT.
Yeah, happy to be here. And mine actually is interesting. When I moved to this country, my parents immigrated here in December '79. Unfortunately, I got sick a lot, and we moved to a small town in South Carolina. And I just remember them taking me to multiple doctors. I had like pneumonia twice, a lot of ear infections, and there was a family doctor that moved into town finally instead of driving 50 miles to see a doctor. And he was just amazing. He kind of went over the ear anatomy and the lung anatomy and explained to me like how antibiotics work. And I was in. I was bought in. And in regards to technology, I've always kind of been tech focused. Always kind of been leaning towards, technology and how we can help business. And just, I just loved playing games when I was small. So it just kind of, I guess, evolved into that track in the future. Became an internal medicine physician. Practiced for about 2 decades at Prisma Health / Palmetto Health. It turned into Prisma Health about 5-6 years ago. I was also the academic vice chair of medicine, so I was over operations, helped with value-based care programs, and became CMIO for the ambulatory group, and then eventually chief digital officer for the entire enterprise, which ended up being Prisma Health, where I really focus on digital transformation. Focus on how do we try to really improve effectiveness and efficiency, meet our quality goals, both clinically and operationally using technology. So while most people start with tech, I actually started on the opposite side, which is the clinical and operational needs and less about the technology. And so got to work with great folks in informatics, IT, and obviously the clinical and operational enterprise. And we're very successful in doing a lot of great programs before COVID and really accelerating those programs during COVID and then thereafter.
That's amazing. And, on this, what we kind of plan to get into today is, and we talk about a lot on this series, is the transition to value-based care and how, kind of the tips and tools and things that, that a lot of the us in the industry are seeing. And so, kind of jumping right in, where do you feel that, most health systems have challenges when making that transition to value?
Yeah, it's interesting. I've got to see this whole journey for the last 2 decades, right? We've always, as providers, worked on quality. We wanted to obviously provide the best care to our patients, but we were all fee for service. It was just, running the hamster wheel, seeing as many patients as you can. And, we weren't really focused on A1C scores and blood pressure and all those things. And then you go through the High Tech Act, which really helped enable a lot of this with the transition to the electronic health system and obviously meaningful use. And we started to have the building blocks to enable value-based care, which is data. But unfortunately, Rich, as you probably have seen since the High Tech Act, a lot of health systems have, merged and EHRs have come and gone and new instances of EHRs have come in. But one of the things that we've unfortunately didn't think about while we're doing this is that we started building all these different tools, but we weren't setting up ourselves for success in the long run because we didn't have unified data. Right. We had siloed data from different programs, different hospitals, different communities, different regions. And in order for value-based care to be successful is to have accurate information about your patients. So you can, engage with them in regards to care gap closures, making sure that their A1C scores or blood pressures get to where they need to be. And that requires accurate data because the last thing you want to do is, again, make insights and have insights off bad information. Which leads to frustration and potentially, potential health risk and increased costs for the patient and the health system.
And what have you seen kind of solutions or, kind of best practices wise in order to get to and achieve that unified data?
Yeah, usually when health systems have a value-based care program, they usually have it as part of a larger network program, right? It's not just the employed providers of the hospital, but it's a larger ACO as part of that. And in order, what you see immediately is the fact that all these community hospitals or those folks in your network are going to have disparate technology. And I think one of the things that we try to do in my past organization is set up a singular instance of through a company like Snowflake, where we brought those guys in and we unified the data in one repository, and then we started to work through that. So I think important piece is to unify your data into one location, irregardless of your EHR. Also work on EMPI and unified identity management, so you know who the patient is. And then what we did was, look at who's our attributable population, and then risk stratify based on risk, and then tackle those patients first, and then prioritize the rest.
And I've heard you say that risk often drives innovation, right? And so when you think about at Prisma, I believe it was a third or even more of the population was under value based care, which is a pretty high percentage. I think if you look at nationwide.
Mm-hmm.
What other kind of what other areas would you say kind of attributed or led to that success?
Yeah, we're in a very competitive market, number one, in South Carolina and the Southeast. But more importantly, if you look at the CDC map around chronic care, heart disease, stroke, diabetes, obesity are very prevalent here. So it's very dark red in the Southeast. And so we needed to get better, outcomes. It was showing that we were, unfortunately at the bottom of the barrel when it comes to rankings in outcomes. And so part of it was we needed to improve the care of our community. Two, we needed to do so because reimbursement was moving that way, and a large portion of our reimbursement is starting to move that way. It was also an opportunity for the health system and organizations in the Southeast. Because of that tight margin on the reimbursement side, we had to do something better. And we had to partner with the payers to say, look, we understand you're paying an X amount per visit, but let's increase that multiple if we're hitting certain quality measures. And so it was a win-win situation for us, and it was kind of we're probably one of the earliest in the country to get that big when it comes to value-based care attributable population, and it continues to grow. And so I think a lot of health systems, what I've noticed at least is, especially in the South, are focused on value-based care. Now it's become a larger part of almost every single health system. Where before it was just a whisper of people talking about it, but not really doing it. And most plans are still fee for service for sure. But I think is moving towards that. And even outside of governmental payers, right? Outside of CMS payers, you're looking at commercial payers also doing the same thing. But this is the future. And if you look at the current administration, they predict that the value-based care dollar is going to double in 2025. And so from $500 billion to $1 trillion potentially in value-based care spend this year. Dr. Oz, I was able to visit with him, and he gave a great speech on what he sees the direction of CMS. And he's very laser focused on incentives and quality payments, not only for the health system, but trying to figure out how to also incentivize the patient to do better for themselves.
And are you seeing that, kind of more and more moving into the specialty areas as well, kind of versus just the core primary care, which is where I think a lot of people start?
Yeah, so if you look, the way we looked at primary care, it's internal medicine, primary care, family medicine, OBGYN, because a lot of women get their primary care in OB, and obviously pediatrics. Now, if you look at what we expanded at Prisma is a very short ... to cardiology, to GI. Right, because if you think about it, a lot of those folks, like I said earlier, heart disease, stroke, you got to have cardiologists involved in the care of these patients. You're going to have GI involved in the care of these patients due to colonoscopies, and so there's a lot of kind of folks that are working with you within that guardrail. So I see cardiology and GI being the big ones. There's also value-based care programs now for oncology, and that is growing significantly because the spend on oncology is pretty large.
Yeah, absolutely. And I think that there's a lot of kind of specialty organizations popping up that are focusing really deeply on partnering in
Mhm.
those areas as well, which is pretty cool to see.
That's correct.
One of the other things that was so interesting when we were kind of, talking earlier is, you shared a pretty powerful statement about, doctors getting paid to document, not care, right? So what needs to change, to improve coding accuracy and align reimbursement with true, the true complexity of the patient?
Yeah, my good friend Shiv Rao actually said that statement, and it really resonated with me. And I didn't ever think of it that way, but it's absolutely true that we do get paid to document and not care. And I think that's the whole reason of value based care is to change that narrative. It's not how long your note is and how complicated your note is and what your E&M bill is based on that. It should be more about the actions that come out of it. And so I think that there's a lot of great tools that are coming out, like ambient technology, that are going to help doctors document better, get paid for what the work that they do, but more importantly, code better, right? I mean, that's unfortunately providers are not really taught how to code, both in medical school nor residency. They're doing better about that now. And ICD-10s and RAF scores and HCCs, they're very complicated. It's not an easy thing. But now, finally, we're getting to a point where we're educating folks, and we have technology such as AI and agentic AI that can actually help us, just by us talking, put together the components. So if I say, Rich, you're a 58-year-old diabetic, type 2 diabetic with hypertension, stage 3 kidney failure, and you've had a stent in your heart due to a heart attack, then when I go down to coding, it's going to go, Nick, this is not an uncomplicated diabetic. This is a diabetic with vascular disease. This is a diabetic with renal manifestations. Now you're putting ACC codes in, which then improves your RAF, which is your risk assessment factor. I think that data, when we start to think about populations and you think about risk stratification, you have to have that information. It's not about, let's just put everyone at this age group or this A1C at the highest tier. It's about looking at everything. You're going to rarely find a diabetic that's just a diabetic, right? Or a congestive heart failure patient that's just a congestive heart failure patient, or a COPD patient. So you have to understand that there's relationships between these organs and these chronic conditions. And hence, so you have to start to risk stratify them based on that.
And how do you see that? Is there how big is sort of the gap in terms of the RAF scores or risk scores right now? If maybe you're using suboptimal tools, or how do you see that gap closing, and how big do you think it actually is?
Yeah, it's a chasm. I would say that's how big it is. It's pretty significant how large it is. Unfortunately, because again, we've been in the post EHR world now for over 15 years, it seems like, and so it's not. It's old muscle memory that we have to kind of relearn, right? It's like, I'll use a Yoda quote: You must unlearn what you've learned sometimes, right? And that's what we have to do. And the EHRs and the software platforms that we use also have to aid us in that and make it easier. It has to move away from just being a glorified data entry system, which in most cases, most EHRs are at this point, but to really giving real-time insights as we're coding and talking to patients. So I think so the chasm is big. The learning curve is unfortunately also big. But even more complicated than that is we have to start to incentivize providers to do it. Right now, if you look at most provider contracts, they're on a fee for service RVU model. Right, the more you see, the more RVUs you make. The more RVUs you make, the multiplier, the more money you make. Right, that's kind of where it is. It's irregardless of outcome. Period. Right, so if you go buy a new computer and you turn it on and the power switch falls out and it doesn't work, you get to return it. But in healthcare, your A1C doesn't get better. You still paid for it. You still get paid. All right. And so we have to start to think about how do we actually incentivize the providers beyond fee for service. And that is to start thinking about quality outcomes and bonus structure. So one of the things as academic vice chair, that's one of the things we did immediately is include the quality bonus on top of your regular RVUs.
In addition to, those are really great points, and I think from the also thinking about it from the patient's perspective, right? I mean, a lot of times the patients is sort of missing from that incentive structure or that value equation, right? And so how do we change that? Because I mean, I think many times patients the I would say industry sort of is happening or reacting around them, and then all of the stuff that happens in the background, oftentimes they don't even know they might be an attributed patient to a value
Mhm.
based agreement. Like how do you think that could change or should change?
Yeah, absolutely. I think we need to gamify this whole process, right? So we have to incentivize the patient as well. Remember, like you said, Rich, most patients don't know that they're part of a value-based care program. So if you have, let's just say, Blue Cross Blue Shield, you have no idea. You're totally blinded by it. And actually, it's double blinded because the provider doesn't even know. So and we did that on purpose, right? We want to make sure you're treating every single patient as if they're a value-based care patient, right? You shouldn't just focus on quality when it comes to getting incentivized. That'll be, again, break a few rules of regulation, right? So what we want to make sure is, number one, the provider provides care irregardless if they're attributable or to a VBC program or not. Two, we need to start incentivizing patients. And one of the things I think where we can start is with partnerships with the payers, right? So the payers, if we got them in a hypertension or diabetes RPM program, how do we make sure that they're incentivizing the patient through, maybe as a discount code to medications, maybe it's most people do free gym memberships, but that doesn't mean that you're actually going to use the gym, right? How do we incentivize them? If you actually do 20,000 steps a day, your premium goes down a certain point. Just like safe driving that most insurers do, right? Where you plug that thing into your car, and if it notices you're driving safe, your premium keeps going down. Well, we need to do the same thing, right? And that's one of the things that a lot of organizations have not done yet, and payers haven't done. So I think it takes a partnership between the payer and the provider to bring up those incentives, and then we need to have the right platform that can actually take those data streams, right? Like Nick walked 20,000 steps today. I can send him through a chatbot. Nick, walk another extra 2,500 steps. You'll get another bonus of 5% off or something like this. Or I'm going to give you a coupon to your local grocery store, and that grocery store coupon is locked in SKU to only healthy items, right? So no sugary stuff, mostly produce, fish, that kind of stuff. Everything in this world is digitized. So we could do that very easily, yet we don't. Or if you go to CVS, Walgreens, name your pharmacy, you walk in and you get a discount because you did your certain things. Just like, when you do your points on your Amex card or your airline, right? I can use certain activated points that you build to buy a certain amount of things out of this digital store. So I think those are the types of things I think we need to be doing. And it needs to be hyper localized too, so that it also makes use of the community and the resources around that person to activate those resources. So I think that it's going to take a blend of technology. It's going to take a blend of payers coming to the table and the health system, and understanding how all those incentives work, in a legal framework that makes sense.
Yeah, it's interesting that the comment about sort of the kind of focused or maybe restricted access to those incentives and what you can buy within grocery stores and diets and things. I mean, my wife and I have been talking about that actually for years, about why that when we invest in those things, that we aren't creating some of those guardrails for for the patients or for the person
Yeah.
around those things. And even when you go into a Walgreens and or a CVS, and the first 2/3 of the store
Yeah.
often represents those things that
Right.
you
Right.
don't even
Candies
want to
and
be consuming, right? Which is
yeah.
kind of an interesting dynamic.
Yeah.
Uh,
Well, the food stamp program's been doing this a little bit on a pretty large scale for
okay,
certain very restricted items like alcohol and tobacco,
sure.
right? But not to the degree of sugary and those types of things, fatty foods.
Ultra processed, yeah.
Yeah, ultra processed. Yeah.
Interesting. Well, that's good. At least we're moving partly in that direction. I think
Yeah.
there's a lot to do, and especially to your point, it's all digitized, so that we should have that
Yep.
data to know, and be able to trace and track to those outcomes.
Yep.
Um, well, let's talk about AI a little bit. I mean, it's a huge topic, of course. It's moving really, really fast, and I think that everyone's trying to figure out, right, where to focus.
Mhm.
Where what is coming from a outcomes perspective, and what guidance do you have about where healthcare leaders should be focused right now? Where are you seeing solid return on investment? Let's dive into that a little bit.
Yeah, so I did some research into this actually through some of my other clients, and interestingly enough, if you look at the top three major issues and challenges health systems have this in 2025, and I think it's going to be beyond that, as it'll bleed over from 24. Number one, and the biggest bubble, workforce shortage, biggest one, right? So that's a big one. Second one is reimbursement challenges, right? That's a huge one. And the third one is overhead, increased supply chain cost, people cost, building costs, you name it. The whole supply chain infrastructure cost is skyrocketing. So all of these things tick away at your margin. So if you think about nurse shortage, huge shortage, right? They say even if you took the 150,000 nurses that are in training right now, stuck them in the hospital today, you still have a massive shortage. So
Mm.
clearly you can't, churn enough nurses out to do that. That's one. Second thing is Becker's just recently reported that approximately 90,000 primary care providers will be in shortage by 2037. So that's just, right around the corner, 12 years from now, not even that far away, right? So that's another one. And guess what? Most value-based care programs rely on primary care, right? So we got to start thinking about that. Nurse practitioners are now 46% of all primary care providers. I was shocked at that number. So there's that. Reimbursement obviously continues to get changed and every year and strains health systems. Of course, thankfully CMS is now going up about approximately 3% on physician fee schedule for 2025, barring that it passes obviously the Senate, but I think it will. Medicaid, obviously, there's some challenges there, but mostly what they're trying to do is eligibility checking and make sure that you are who you are and you're supposed to get these benefits. And those who are on it are, doing their part by trying to get a job and those types of things. When it comes to supply chain, well, everyone's dealing with that sort of thing, right? Everyone's paying more at the grocery store and everything else. So again, that it is going to add a lot to the cost of the bottom line. So where are people should be focusing is around those three. Number one, workforce shortage. So a lot of AI-based nursing platforms that people are bringing for virtual nursing. So you can augment your nurse that's there, boots on the ground, so you don't burn them out and you give them incentives and their nursing ratios improve. I see a lot of that too. Again, provider burnout is a huge reason for the shortage. A lot of people are leaving healthcare industry because of burnout. And so how do we get them to bring joy back into work life? And where most of the angst around burnout is documentation.
Mm.
So ambient documentation companies, as you know, are helping with this, are trying to help with that. But again, it's beyond documentation. It's the rev cycle. It's all these other components of data to insights to agentic AI that helps you close care gaps based on practice protocols, et cetera. And so those areas for AI is being used. AI is also being used again to help normalize data. So you and I talked about big data and how do we get those insights? Well, we got to have to be able to normalize. So we start to see relationships between diagnosis and names between, like Nick A. Patel versus Nick Patel, or my real name versus last name is the same person, right? Understanding all of that and also taking in all those flat files that we still get, PDFs, and getting and sniffing out that insight from use of OCR and NLP to AI to actually helping us get to a point where we automatically put in a chart and we close care gaps because the colonoscopy was done externally. So those are some of the areas that I see AI being used for now. I think AI will get further into true data insights, to real world evidence, to again, to actually remote robotic process automation, to agentic AI ultimately, where it goes from data to insights to action. And if we can do that in a seamless way, then that's what's going to help us with overall efficiency and liberate our medical staff who has been eyes glued to a monitor since the HITECH Act, to liberate them to the bedside. And I think that's where it's going to focus on. And then we're going to get into a lot of other really neat things when it comes to where AI can go beyond robotics and surgery, which is already kind of happening, to computer vision, which is already happening. So future is pretty interesting and very exciting.
Yeah, definitely. I like the care gap use case, and like I think you're right in terms of the technology is now there to kind of piece together that agentic workflow around being able to first and foremost leverage Gen AI. One of the things we're working on is
Mhm.
having the Gen AI be able to identify those cohorts, right, by the
Mhm.
kind of certified definitions, and be able to automatically detect and categorize patients into those cohorts that represent those care gaps that need to be closed, and then kind of handing that off to that next agent in the pipeline, and kind of creating that agent swarm, if you will, to be able to come in and solve a workflow, even first from the identification, which is interesting, right?
Yeah.
Obviously, appropriate human in the loop as necessary to make sure that things are tracking, but it's an
Yeah.
exciting time. And also with even just contracts, right,
Mhm.
leveraging in contracts, and then
Yes.
adding that decision tree on top of that data asset can be very powerful, and just a huge time and spend reduction for large
Mhm.
workforces.
Yeah, and I think if we do this right, we'll be able to consolidate some of those tools. I mean, the average health system,
Yeah.
a large health system, can have 800 to 1,000 different technology tools. It is crazy. And so what the other thing we have to be careful of is we need a singular line of communication back into for the provider to the patient. So we're not getting 20 different texts to a patient or outbound calls to a patient. We're doing this very seamlessly. So, one it may be that I need the patient to get a colonoscopy, but an OB says, "Oh, I also need a Pap smear." I don't need two texts going out. What I
Right.
need is, "Hey, your providers, Doctor X and Doctor Y, want to make sure that you get your colonoscopy and mammogram or Pap smear and mammogram scheduled. Let's do that in a singular way, and let's then take that to go to self scheduling and pick a date, and then reminders, and then here's your prep. Oh, Nick got his prep, great." And he knows what he got the checklist what to do before 24 hours for a colonoscopy. He got his wife got the education on the mammogram, what to do, and all that. So it's just all these things kind of need to be put together. Instead of right now, what's happening is patients are getting pinged from every direction based on the tool in which is again interacting with them.
Yeah, absolutely. And it's interesting you mentioned that kind of I call it kind of clinical and operational workflow coming
Mhm.
together, right? And as someone who's kind of worked on both sides of, both on the clinical side and as an executive, what are some ways you've been able to, better bridge those workflows to make sure that the patient isn't, kind of caught in the middle of a siloed opportunity?
Yeah, unfortunately I'm going to say the dirty G word, which is governance. You got to have governance, and I see a lot of people doing these things in silo marketing. Thinks they own all of engagement, and they work towards that. And then you got digital teams, you got IT teams, you got informatics teams, and no one's talking to each other. And I think they all need to be at the table, because at the end of the day, we're in the healthcare business, and there are parts that are engagements, there are parts that are clinical, some are operational, some are workflow, some are technological, and we all have to be at the table, right? And almost have a knights of the round table around this, right? And unfortunately, that's not happening, and hence this is why health systems end up with 5 RPM tools, because one guy went over here and one guy went over there, and now you got 5 tools. And so I think part number one, got to start with governors. Bring the right people to the table, and have a conversation about each use case. Be use case focused and operational use case focused, and design around it. Design it out exactly what's going to happen in each step and where's the overlap. So the goal should be to look at, here's all our top use cases. Now look at what technology can take care of all of them, not each one has a separate technology, right? Trying to unify that. And then I think that starts with decision making and governance, and that helps again. Hopefully if you do it right, you could even be cost neutral because you cut out 10 other tools.
Yeah, interesting. And when you talk about the use cases, and I know you've had analytics experience across a ton of different domains, kind of data from real time sensors, from just like core EHR claims. I mean, what have you found to be the most, I guess, valuable, or where would you start, right, on a journey? Like, we see people trying to jump all over the place, but
Yeah.
what have you seen as sort of like the highest value metrics or data sets or analytics?
Yeah, I would say that probably the easiest and low hanging, if not on the ground fruit, is care gap closures. Start with that because it's very predictable. It's based on United States Preventative Task Force data. It's standard across the nation. Start with that, and you don't need too much information other than their age and gender, and be able to do that. So you could start with the lowest hanging fruit. That would be that. Second would be to get to clinical improvement. So most people are starting with diabetes because we know that is kind of unfortunately, the catalyst that causes everything else, right? Heart disease and stroke and kidney failure and blindness and amputations, all those things. So I would say diabetes, hypertension next to get those two, LDL lipids as part of it. But you're now looking at, and each one of those, the good news at Rich is they're all discrete data. So A1C is a lab, blood pressure is a vital sign, LDL is a lab, and it's again discrete data field, right? Creatinine, again, discrete data field. So you should be able to get a good picture just with those things, right? Then you get into some other things that are, again, could be coming in from other areas, outside of social determinants of health, but again, putting in the larger overall risk RAF score on each patient based on that. So it's kind of a tiered process. You have to have a good foundation to get to the top of peak patient 360 and a true CDP, and that's where I would start. Number one. I would start with certain players, and wherever you start, you don't have to go through all entire population. I would start with a population that is a high risk, and then kind of go over, try to work with those payers in that direction. But you need to also, again, align your provider contracts, and educate your providers on this is what we're doing and why we're doing it, and make sure that they have the right resources. Like when you do a value-based care program, you got to not only have the technology and the data reporting, the provider scorecards, which we provided, you also have to have care coordination. You have to have PharmDs, because there's a lot of opportunity. And then there's certain things like annual wellness visits for Medicare population, right? So if you're already going to get value-based dollar on that, well, go ahead and do an annual wellness visit, because that's going to help you not to capture an E and MG code. It's going to let you get quality care gap closures, because that's the whole point of AWV. You could do it virtually, so you don't have to come in. So you could centralize that process, right? And then third, you're going to get actual quality dollars once you close the care gaps, and you're going to get downstream revenue from MAMOs, COLOs, and DEXAs and other things that you need to do. So I would start to think through that as well. As like, how do I get the largest cohort of AWVs, then move to transitional care visits, then move to chronic care management. And this is why RPM has not really scaled anywhere, because RPM, you're going to have all this data coming in. If you don't have an AI framework on how to handle that, or an agentic AI process, then you're going to push everything back to a provider, which we already said we have a big shortage of. So we have to start to think through is, how does this data come in? Number one, how do we separate the signal from the noise issue? Second, how do we help the AI agent escalate when needed? And when does it send a chatbot to go, Rich, I noticed your last 3 blood pressures are high. Are you taking your medicine? Did you miss a dose? Do you need someone to call you? Are you having symptoms? Basic questions that any nurse or provider would ask you. You're not going to just change your blood pressure medicine because you had one elevated reading, right? Or now, we have wearables like continuous glucose monitors. You just wear a little patch on your arm, and all that streaming data needs to be handled as well. Right. So I think it's just understanding the blend of how we have both AI and the human in the loop. And how we're going to do that. And I think part of it is setting up a centralized process to do that.
Absolutely. Well, it's super, super interesting and amazing insights. Dr. Patel, thank you so much for joining today. It's been a really great conversation. I learned a lot, and I think that this is going to be a great episode. So thanks again.
Great. Thank you so much, Rich.